computer audio, I guess.
Let's go Instagram. I verified for Instagram.
Sick.
So, well, I mean, I applied to verify.
Nice. You're like actually slower now.
So you either get 10,000 people for verification, or you
apply.
You apply, and you can like your stories can have links on it. So,
yeah, nice.
like for example, for that pain talk, I could have just hit the link. You could just click it, and it would be there.
Totally.
Then the U of A would be paying us. Hello, everyone.
Hi,
Hello.
everybody.
Hello, Marco. Oh, we got some registering people. There we go. Sorry, I'm pretty informal today. I have a hat on.
I know, we're like the opposite today.
It's a company hat. I was wondering, I was like, is Brandon going to dress up? And he's always sharply dressed. So I just thought, you know, I could wear whatever I want. But I don't know, maybe I should dress up every time. But my thing is like, and this is going to be maybe a bit funny. My fear is, right, like, yes, everything's bad. Can't get hair done. My thing is like the salon or the studio I go to sells these awesome products. And if I run out of hair products, what am I going to do then?
I'm in the same boat.
So I got to like ration. So the hats are really just to conserve hair product. I'm not lazy, I promise. Instagram and followers.
We were talking in a meeting yesterday. How many people cut their own hair already? And out of our team, the majority are male, but 3 out of the 8 people already cut their hair.
Are you serious? 3 out of 8? I thought you said there's an article that here's why you don't cut your hair at home.
So I thought it was pretty funny.
Jeez, that's hilarious. I mention it every time. Every time we go live, I'm like, oh, Brandon told me why you shouldn't cut your hair by yourself.
I'm getting pretty close. Not myself.
Yeah.
I'll get the wife to do it.
I'm good. I'm growing it out. I just gotta get the back lined up. That's all, like the neck area. Too much detail, I guess, but
you should go traditional. Grow out your hair long.
Just all the way down.
Yeah,
I could do that. I could do it. See, look, it's not bad.
Oh no.
No.
It's nice flow.
It is nice flow. I'll put that right back on now. This is brought to you by Hyper Ice.
Not officially.
Not officially, but Hyper Ice. I'm icing my knee because it's very sore. I haven't taken a break from training, so.
That would be funny with like sponsors. This is brought to you by Squarespace.
This Instagram Live is sponsored by Nike. Thanks for all the free stuff. No, we're not sponsored by Nike.
That'd be cool though.
Where's all of our Zoom peeps? There's usually more Zoom peeps.
It's only 12 now. We'll wait 4 or 5 minutes.
Yeah.
Get the ball rolling here.
There's this one, but I don't want to use that because that's kind of too morbid for dad jokes. There's one about graveyards, and I don't want to say it. What do we got here? I saw a good one about penguin. Where is the penguins? Why did the Invisible Man turn down the job offer?
Why is that?
He couldn't see himself doing it.
That's good. I like it.
Here's the. Unless you have any of your own, Brandon.
No, I wish.
No. Rob said he thought of a good one the other day, but then he forgot. So I don't. I turned the waiting room off, so now like I don't have to like.
Nice.
Hey,
less secure though. You should know that.
Yeah, I know. But like this is like we're not hiding anything. If someone's gonna hack into this video, they must really be interested in rehab.
Yeah, but if you stay tuned, I will show you my credit card number. And CFE ID.
Screen share your bank. Oh god. Here's my SIN number.
Yeah.
My mother's maiden name. Done. Someone could take over your whole life.
Welcome Zoom people. We're gonna wait till about 12:05, I think.
12:05. Oh, yeah, in the house.
Nice.
The 6 T dot. Big city. I miss it.
Maybe we should ask Yehaya with is Drake in quarantine in Toronto?
Yeah, where's Drake in quarantine? OVO Records.
We need to know.
Or maybe he's just flying on a plane permanently just to stay, above everything.
Yeah.
Just to maybe that would increase your chance to get another virus, I guess.
Yeah.
I was telling Brandon just a few minutes ago that I miss human contact, but also I was getting my groceries yesterday and obviously don't like going out to get them. And I forgot a product and now I'm pretty upset. So I might have to, actually I could Amazon Prime it.
You could, if they do it now. They're limiting a lot of items.
Oh yeah, that's true. I forgot deodorant. Yeah, so now I have to.
So Sign's gonna have to go.
I might just try to like text a whole bunch of people and say, who's going to the grocery store in the next couple of days? I can smell like BO for a couple of days. I'm cool with that.
Yeah.
Or
So we were talking as well in our
who's
meeting.
getting stat pay? Not us.
We were talking in our meeting too about like things. We're like, oh, like work on it tomorrow. And somebody's like, oh, it's the holiday. Like it's Easter Friday tomorrow. I'm like,
it doesn't matter. Oh, that's a stat holiday.
I was like, doesn't matter.
Let me check my payroll department. Hey guys, let's talk about payroll. There's no one there.
Yeah.
I'm sorry, it's a bad joke, but it's so true. That's funny.
So yeah,
That's sad.
that'd be interesting. It's a holiday tomorrow. I wonder if it'll be the one time probably in a while that it'll be like a holiday that nobody cares about.
It's canceled.
This is canceled.
The Easter Bunny's not going to be hopping around, that's for sure.
Yeah.
Oh man, this is better than the dad jokes. Shoot, current events. Joking about current events.
Current events too.
Oftentimes I sit here all day, and again, like, we have no direct patient contact unless it's like an emergent issue, which there's not too many of. And I often say, "Who said that?" as a joke, and sometimes I say it when no one's around, and I'm like, "Oh, I don't know how I'm gonna do another month or two of this."
Yeah, you're slowly slipping away.
Just a little bit. It's okay. If someone doesn't hear from me in the next like 48 hours, I mean the clinic address is on the profile, just to come take a look. Yeah. I'll be okay. Like I'll just need a little bit of help to get my composure together. Oh, some more Toronto in the house. What do we got here? Might as well cancel 2020 at this point. I would agree. Yes.
Oh, we were also talking too.
How do you cancel a year? Like, does that mean you live an extra year longer, or what?
Yeah, we're also talking about like how everybody was like, "Oh, 2019 is such a bad year. Can't wait till the new decade."
Yeah. I was like, this is gonna be our year, new clinic. Let's do this. And then this happened, and I'm like, I'm still glad I went into business. Yeah. I'm still very happy with it. I hope Brandon is as well, even though we're not seeing any patients actively. But
all good.
Yeah, you know, it's a nice place. Once this is all over, we'll do free tours.
We'll eventually have like a stellar opening party.
Yeah, eventually. Launch. Well, I was thinking, I'm like, our opening party is supposed to be in April. It got changed to May. It's going to be canceled.
Yeah.
No surprise there. And I thought August 1st was their opening day. So I'm like, why don't we just do like an opening anniversary, like all in one?
That's awesome.
And then get people just like party, like come out. By then, hopefully everything's fine and people will be itching to
see people,
to go, to see humans. We'll get a DJ in that corner there. Get a liquor license, I guess.
We were talking to that. What's one thing you think that won't happen after the pandemic that people did before the pandemic? Mm-hmm. And I think it's handshaking.
That won't happen?
I think people are going to be less likely to.
Yeah.
Yeah.
Less likely to handshake.
I think so.
Then it might be less likely to go out in groups then.
Maybe.
Then our relaunch party is going to happen. Like, we don't go 2 meters apart in here. How many people would you get? Like 30, 40 maybe?
I know, but we should do it. That'd be interesting.
You could raise the beds up 2 meters and then there's like a next tier, right?
Yeah, exactly.
Yeah, it's true. Like, I
don't know.
That'd be weird because I'm a person who believes in a solid handshake, right?
Yeah, I don't know.
Like if I was meeting, somebody for the first time and they were supposed to impress me, or like it's a business meeting or something, and if they give me a weak handshake, I'm like, I'll destroy you. That's what my lawyer, amazing gentleman, he almost crushed my hand. I'm like, I like this guy. If he goes to court like he shakes hands, he'll destroy everyone.
Exactly. All right.
Okay.
Wow. Hey, I think we'll get rolling here. Got a nice little audience here.
This is good.
And Zoom people, I think we're all in there too, so that's
Yeah.
good. Yeah, so I guess today was a bit of a continuation of last Thursday, but we're gonna just be a little bit shorter today. We're gonna kind of focus more on the management side, and yeah, I'm gonna talk a little bit of just intro, just give some stats about back pain research. Just from that end, we're going to talk about just some questionnaires. I think not so much questionnaires, but flow tools as clinicians and patients, I think are quite helpful. We're going to talk about guidelines, especially for clinicians and yeah, even patients too, to figure out where you can find them, because they're often like hard to find and they often change. And we'll talk a little bit of the research behind those guys. And then finally, we'll kind of talk about just programs that manage it. We'll talk a little bit about GLAD, and yeah, whoever clinician-wise was able to watch the PT Alberta presentation on GLAD this morning with our research team, Dr. Greg Kotchuk and myself and James were there from our team, our lab that's been working on GLAD projects. Yeah, thanks for joining us. It was great. The organizers said it was one of their top attended events, close to the Bill 21 change. Yeah. But it's interesting because we're in interesting times because it was at 8 a.m. and a lot of people were able to attend it just because we're not seeing patients.
Piece of cake.
So yeah, so it's kind of like it was neat that happened. But obviously, thanks for joining us. I hope you guys learned a little bit. And then maybe at the end, if there's clinicians that did have questions on that particular webinar, well, maybe we can answer them here as well. I think that might be neat.
I think that'd be great. Yeah, I know Brandon asked me like, well, what's your schedule like for this meeting? And I was like, well, it looks like this. So it was great. I liked it. I didn't even notice the time go by, to be honest. So.
Oh, that's good. Yeah. I'm glad Sonny enjoyed it. He was joking around that I couldn't connect to the audio.
I was like, he's probably.
So Sonny was joking that I was like in a ditch somewhere, down in a ditch or something.
I thought he had one of those traditional Wednesday night benders.
Yeah. So reassured, I connected at the end, and it worked out quite well. So yeah, without delaying too much longer, let's talk about management. So I'm going to open up a PowerPoint that I actually made last week for a class, but it is relevant for today. So we'll talk a little bit from that end.
I'm going to take off my ice pack here.
And Zoom people, I'm going to share my screen, and Instagram peeps.
I will share the screen as well. This really fancy technology called me holding the tripod. All right. Oof.
Okay, I'm just going to make it full screen. Let's see if that'll make a difference.
Maybe I'll do the blinds. I don't know. That helps, but there's a bit of glare. I'm trying to figure out how to get around this issue.
I think it might be the blinds. Okay, I'm gonna close the blinds real quick.
We're gonna close the blinds, guys. Sorry,
people.
Apologies. I will hold this right here. Yeah, and then the one to the right.
You're right.
You're right.
Stage right.
Let's go all the way down. All the way. And the other one all the way too. Just because it goes, yeah, there we go. That's good. Nice. And then I could do that. There we go. That should be good.
All right.
You're way too much.
Yeah, so we're just going to look at this one slide here. It's a little bit just background with back pain. And those who saw the presentation this morning, that picture on the right here doesn't look any different. So non-specific low back pain is a worldwide phenomenon. And the global point prevalence of activity limiting back pain is just to be affecting around 540 million people at any given time. Majority of adults will experience non-specific low back pain sometime in your life. And as a global disability study, it's one of the top causes of global disability. That includes like missed days of work, missed days of activities, and also this general satisfaction. This is an interesting stat. It's estimated in the U.S. Healthcare costs associated with chronic pain and costs related to lost time, productivity were about 560 billion per year. In Canada, those stats were kind of look between 56 to 60 billion per year as well. So obviously quite a problem of how much we spend on chronic type pain type stuff. Mm-hmm. And what's interesting is in disability is linked, especially with low income countries, meaning there's higher disability in countries that don't have a lot of money. But what the problem is in countries that do have more money, like US, Canada, those ones, the amount of money that is spent on low back pain and also chronic pain doesn't correlate with necessary better results. Yeah. So part of that includes, if you want to think as clinicians and also patients, that also includes like imaging studies, right? X-rays, CTs, MRIs. Sometimes a patient might have like 2 MRIs in a year, or like have like 6 X-rays or something like this. And maybe Sunny can talk maybe with some of his case, not specific, of course, but maybe some people that definitely fall in that category of they have had lots of imaging studies, but pain and disability really hasn't changed.
Exactly. Yeah, I've seen a lot of people get imaging and nothing really shown, and
yeah. So and part of that is to do as well as also treatments that aren't necessarily show not promising results. I shouldn't say that. They don't have high evidence as far as helping people with low back pain. It does include like injections and a few things that were some populations they work on. That's okay, but majority of chronic back pain people it doesn't, and they have a high cost associated with them as well. So that's one of those problems there. All right, so generally management and more modern models of pain management fall into the biopsychosocial model or framework. They really move away from that biomedical model perspective. And for our U of A people, this shouldn't look too different here. This little graph here, that's actually from this Dr. Boschek. So you might have seen that little infographic. So what is the biopsychosocial model and when it's pain specific? Well, it's kind of a multifactorial way to look at what pain is and how to manage back pain as well. So for example, biological factors include components like genetics, gender, immune response, and comorbidities. Some of those we don't have too much of effect on in physical therapy. Some we do, of course, like movement and stuff that can help with different muscles and blood flow and all that good stuff from that end and help with comorbidities from that perspective. Social factors can involve family and community support, job satisfaction, work demands, and self-coping strategies. Again, think about just general support, even your own families. Think about how you generally deal with pain from your end. So those are all things that come from a social perspective. Remember, economics also play a role just from a research side. And think about sometimes it's a vicious circle. You're living with chronic pain. You have a harder time to work. Therefore, you can't work, you can't make money. So it kind of gets into a vicious circle sometimes when I say economic from that end. All right, and finally, psychological factors can consist of anxiety, depression, fear, and pain catastrophizing. Those are things that I'm quite interested in as a researcher, but also as a clinician, and things I'm going to use as a framework when I start to do my research designs for my PhD. So what is pain catastrophizing? We're just going to go over it real quickly. So it is a psychological factor. It has been suggested to be one of the most reliable psychological predictors of pain and distress. Pain catastrophizing influences pain of making the injury worse. So example I always like to use is Sunny is camping.
Nice.
And he goes and he grabs a hot pole or something from the fire that was real close by. Yeah. He burns his hand. He learns from that event, and most likely, Sunny's not going to touch the fire again.
Probably not.
Probably not. I don't think so. So there's a powerful learned effect from being in pain, right? Sunny's going to avoid that movement as much as he can. He's very, likely not going to put himself in that situation. Back pain, especially when it's going on for long periods of time, totally has that effect as well. And we can think about movements that we tend to avoid. So like even like bending over and tying your shoe because it hurts, you just stop doing it. So you start to use like a pole or something to put your shoes on, or you just like stop organized sports. You say, oh, my back is killing me. Hockey always makes it worse. I'm going to not continue with hockey, So that's something that just I can't do anymore. We'll talk more specifically about activity modification from that as well. it has a powerful emotional and cognitive factor. We talked about that. It can cause a cascade effect that enhances fear, movements, and avoidance behavior. And because the relationship with pain, catastrophizing has been suggested to be a risk factor for pain-related disability. So meaning that we kind of know pain catastrophizing may have a strong effect to predict pain disability. Yeah, so two kind of different things, but possibly a different effect. So one more model we're going to look at is just the fear avoidance model. This is, it's a well-established one. It's nothing new. It's kind of been suggested since the 1980s, which have been gone for a while. It's been kind of redefined in the 90s and even 2000, but kind of elaborates more onto that kind of theoretical framework, suggesting somebody with pain experience can go two ways. One is they don't experience any fear of what's going on. They just confront it and they recover fully. I'm sure we all been in those cases. You know what's going on with your pain condition. Let's say you twist your ankle and you did it a bunch of times. You know it's going to last like 2 or 3 weeks. You don't really care. Maybe I don't care. You're just like, okay, I'm going to get better. You start doing your rehab. That's great. You know it's going to get better, and you probably will recover.
Yeah.
And this, the negative effect, that learned pain experience that I talked about with the pain catastrophizing on the last slide. So Sonny touches that fire log. He knows it hurts, and he starts to think about it more and more. It can give him some more pain-related fear. He starts to avoid, doing activities, and it can lead to disuse, depression, and disability. So it's a powerful model. It is an interesting framework, but it's well rooted in a lot of modern pain management programs. And when I say that, I'm talking specifically to MSK programs, physical therapy, chiropractic, exercise, physiology, all that kind of stuff that we're generally trying to get people to move. Having said that, when you are in pain, and let's say your physical therapist is trying to get you going through movements and it's starting to give you a lot of pain, and you've definitely been down this road before, you're going to definitely get into these zones. And your physio is trying to get you to go through these flexion exercises. Is the pain maybe going to get worse? Yeah, absolutely. So you can see from our roles as clinicians and as patients, it's definitely a two-way street, right? We can't just always tell people we need to, you need to start doing this exercise because it's going to make your back stronger. Well, no, it's more complex than that. It's definitely a give and take type relationship there as well. So just practice, why is it relevant? Like I said, it's been more rooted in modern pain management type stuff because it empowers the patient to be active participants in their planning and treatment. Pain catastrophizing is relative with increased emotional distress, disability, and heightened pain experience. Fear avoidance can ultimately lead to disuse. We kind of talked about that, disability and depression. And of course, physical therapy, and I think this is why Sunny and I like being clinicians and physiotherapists, can play a major role in breaking this fear avoidance cycle with active therapies. And I think if you've been patients at our clinic or maybe even people just been following us, we're really focused on having a large chunk of your rehab being active because a lot of these reasons that we described above. It's that's one of the major reasons reasons behind that. All right, that's my little tiny PowerPoint. Maybe we'll keep this camera here though, Sunny.
Oh, sorry.
Yeah, all good.
sorry.
Lots of stuff to share today. It's like sharing day, like in kindergarten, everybody brings an object from home.
I miss those days. I don't know what I'd bring these days.
Maybe bring in like a rock or something.
Yeah, my pet rock.
Yeah. All right, so what I got here is the musculoskeletal clinical transitional framework. So definitely a mouthful, but what it is a clinical tool that can help organize a lot of these factors looking at a biopsychosocial perspective to managing pain. I find oftentimes with clinicians and even patients, we get overwhelmed with all these things that are affecting our pain that we often can lose track of what is going on. So think of this as a little bit of an organization map, and it's researched. It's part of the. I'm going to get it wrong. I'm going to look at the bottom here because it's probably referenced. It is part of Curtin University in Australia. So that's O'Sullivan's team and Mitchell's team. do a lot of this kind of research down in Australia there. So it is researched. It is a fantastic tool. Unfortunately, there's no like digital version where you can like slide things around, but from a paper copy type thing, it can be quite helpful. So for example, we'll kind of go through it here. So the first little bit, individual's perspective with pain. So kind of like individual's problems. So of course, stuff we always take during our history, functional capacity, current. So that could be subject. Those are things you can measure in the clinic, right? So think about all your functional testing you can do in the clinical setting. And of course, this is one that's often missed sometimes. Goals are definitely taken, I'd say like 99% of the time in physical therapy interviews. Maybe less than that. I don't know. That'd be an interesting research.
That'd be a good article. Yeah, that'd be.
But this is an area I don't think maybe less than like 50% of people do. I'm just throwing out these numbers. Expectations. So do therapists and patients actually go through expectations of why they're actually sitting and visiting you in a clinical setting? I don't know. I don't think that's discussed enough or a lot. A lot of times if you'll ask us expectations, and I'm going to go from two perspectives. Sometimes patients will say, you know what, my doctor sent me here. Okay, good. Yeah, great. But why are you here? Like, why did you book this appointment?
I find a lot of the times people don't know.
Yeah.
And if you don't have those expectations, buy-in, this could be difficult.
Oh, yeah.
Expecting, okay, this is going to be like my pill where I'll take it and feel better. But no, a lot of the education and goals and expectations need to be laid out.
And maybe like Sunny, you could maybe describe like that case, or not a case specific, but just from your clinical experience that it doesn't make it harder when people don't know why they're showing up at or seeing you when they're sitting in that chair and you're trying to evaluate them. Does it make things quite more difficult?
Oh yeah, for sure. It's definitely like could even be resistive sometimes.
Yeah.
Because they're told to go physio and they're not told, maybe they're not told what physio is, or their idea of physio is like from friends and family, and then they don't expect what they get from us is kind of different than what they expect.
Perfect. So and part of that discussion is going to be guidelines. So we'll talk about that, because what Sunny was saying, that expectation sometimes, let's say you went to 10 different clinics throughout Alberta, you probably will get 10 different treatment experiences, which isn't a bad thing. Uniqueness and customization is important as far as a patient experience, but sometimes when we get a lot of these different factors, we start to lose touch of what works. So that's one thing that I think from patients and clinicians. So if you're a patient, you can say, you know what, I really don't know why I'm here. Could you explain what you mean by X treatment? Can you explain what you mean by Y exercise? I don't know why I would be doing that. That sounds silly. So it's a two-way street that Sunny and I kind of talked about. But if both people are discussing that, it makes things a lot easier.
For sure.
Diagnosis. So these are things, obviously, what's going on from like a biomedical perspective. We can't ignore biomedical perspectives. So specific diagnosis. So let's think about some in our head. So we can think about degenerative disc disease. We can talk about like spondylolisthesis. We can talk about fractures, all those kind of things that can go on. Any other, I don't know, those are just like big group categories as far as back pain. We could talk like days and days, not days, but maybe an hour on back pain diagnosis. And then red flags, okay? Remember, there is situations that you might be in physio, or as clinicians, you might show up at a primary clinic or primary care clinic. So physio, it happens a lot of times where, you know what, as physios, we think there might be something more going on. It's out of our scope of practice, and we might need to refer you back to your doctor or somewhere else, because it's just something that we don't think is appropriate as far as physical therapy. So I'm gonna test Sunny here. What are some common red flags, or what's things you learned as far as really solid red flags?
Solid red flags for back would be like having cauda equina, so losing control or sensation in your lower extremity, bilateral, so both extremities. You'll have like, so bowel and bladder would be another one. Usually it's the bilateral symptoms going down both legs.
So I'm going to address these questions here. This is great. I love the technical selfie stick. That's good. How do you ask a question of why if you just don't, how do you ask a question of why if you just don't know? As I go through this journey, I have learned to ask why. Took many years though. Okay, that's an interesting question. And I'm guessing that's a patient perspective from that end. And yeah, and I think, let's see, how do I ask the question of why? If you just don't know, that's a good question, right? Like, how do you're going to a clinic and you're expecting to be an expert in their field to guide you with some treatment.
Yeah.
Having said that, I think as like you said, as you go through this healthcare journey and you learn now to ask questions, I think it is a learning experience. But sometimes in your head, if you just don't think things make sense, or you're having an understanding of like why you're going through this like treatment cycle, I mean, that's part of our job is education. And I think that's one of those things that takes learning experience, but I think it is quite valuable. So hopefully, Stephen, that answers a bit of your question there. Okay, move on here as well. And I think part of that, maybe Sunny can give some perspective. And I think we all grew up in a biomedical perspective. When you see a doctor, often they just need to get to the point. It's nothing to do with their, as far as ignoring you. It's just they're busy caseloads, and sometimes they just need to get to that question. And they need to get that out of you as quickly as possible. So yeah, part of it, and sometimes they'll have on like the. I've been to doctor's office where it's like no more than 2 complaints or questions or something like that. You know what I mean? So anyway, it's just like I think we've been trained in this medical system as well to conform with those answers from that end. So those are from red flag perspectives. And a few other ones that Sunny was, I think, getting to was also potentially like cancer, fractures. Those are all big ones that we've been trained to kind of look out for. We're not going to get specific, but having said that, like most people will fall into this category here, non-specific low back pain, which means that it's just like so complex, or not complex, that's not the word. We just, there's a lot of things that can be contributing to that pain factor. Looking at the stage of the disorder, acute, subacute, recurrent, and chronic and persistent. Acute's generally going to be those like first 1 to 7 days of like you slipped and fell on some ice and your back is hurt. Subacute is somewhere between that 7 to 21 day period where, things are kind of tapering off, but you might be still in some pain. Generally, when we talk about chronic pain, this is kind of the line here. We kind of leave it there. These are like usually take care of themselves. And in healthy individuals, these are generally back pain episodes that take care of themselves. Recurrent is kind of that, sometimes we describe it as patients as flaring up and, so I'm in a flare up period, things are kind of getting worse. And then chronic, as far as like from a technical perspective, anything that's lasting more than 4 months, that generally falls into that chronic persistent category. Mm-hmm. Okay, pain features. We talked about this last week, actually, so I'm not going to dive into it too much, but nociceptive, neuropathic, nocioplastic, and mixed. So this is a good way to kind of just visualize in your head kind of what your hypothesis with your assessment, what's going on there. Psychological factors, we talked about that before, so there we go. Our cognitive factors, our affective factors, those are more of our emotional factors that are going on, and our social factors, which we talked about in those previous slides. Work consideration, again, remember, especially with workplace injuries, or if your back pain is preventing you from working, those are going to be factors you need to think about as well. Lifestyle factors, so those are those risk factors we talked about a little bit. If you're a smoker, or if you're just generally less active, diet, all those kind of things can play a role into the whole treatment thing. General health and comorbidities, so whole person considerations. Those include coping factors as well, so big kind of scope there. And functional behavioral factors. And this is what I was talking about with that fear avoidance and movement cycle. So is it impairing the movement? Is it actually helpful? Sunny can think of those cases and where pain, acute pain and avoiding movement is totally helpful, right? Mm-hmm. And I gave the example of putting your hand into fire. That is totally helpful. Or you sprain your ankle, it's like the second day and you start to run on it and it's like 10 out of 10 pain. Yeah. That's totally helpful. that helps
protective.
you from not like continue to damage and fracture your foot. Having said that, we start to get into that other phase of the cycle where, you know, pain behaviors can become unhelpful and start to actually decondition and make things actually work worse in the long run. This is kind of just a clinical mindset or thinking. So you have your diagnosis at the top there, the stages that we talked about, and important contributing factors. So you almost get like a bit of a fingerprint of just kind of all those things you need to start thinking of when you're a clinician and, of course, patient, that can start contributing to those factors as well. Okay, I think I got one more sharing thing today. Like I said, it's a sharing day today.
Sharing is caring. Yeah, I find the good point to make, like with the how to ask why. I think it depends on your practitioner too. If they're very quick with you, or just kind of getting things done, then it's harder to ask that question. And some patients even feel like a stigma of asking a question, that they think they're not like intelligent or something enough.
Yeah.
And it's up to the practitioner to make you feel comfortable to ask those questions, right? If something's not in your scope, you should feel free. You should be invited to ask questions, right? So I think as a practitioner, to whoever's watching who's a student or a physio or any medical professional, I think it's good to start by saying, if you have any questions, like, don't hesitate to ask me.
Yeah, exactly.
I think that gets missed sometimes.
Open the narrative, again, because oftentimes it's just like sunny side. It's like, oh, that's like a stupid question. Why am I going to ask it? They're going to be like, oh, but yeah, no stupid questions.
No, not at all. I haven't had one stupid question as a physio.
Yeah, just stupid questions that we ask each other all day. Yeah. As physios talking to each other.
That happens a few times for sure.
Okay, so let's talk about clinical guidelines, because that's kind of the next logical step in as far as management of pain and back pain. And maybe Instagram people and Zoom people, let's do this. Instagram people, if you heard of clinical guidelines, can you give like a thumbs up or a wave or something? People on Instagram, if you've heard of guidelines before, and patients as well, if you heard of clinical guidelines, maybe we can do a quick thumbs up. And people on Zoom, there's also that like hands up button or whatever. I think you can give like a hands up if you've heard of guidelines as well.
Oh, sorry, I keep screwing up the camera. We got a thumbs up.
Got a thumbs up.
One thumbs
Great.
up.
That's awesome.
We got some activity on Zoom as well. We got another thumbs up. And another thumbs up. Oops. I think we got most of them. We got 3 thumbs up, 4 thumbs up, technically.
Okay, yeah, so specific guidelines for back pain. Sometimes you'll see like a poster in your doctor's office of these on the wall. And you know, you're a kid, so I'll give you a bit of background. My doctor is very, has a, I would say like an old school practice. The beds don't fit. And meaning that, so just a lot of paper information and posters up from that end as well. But having said that, yeah, you might have seen these in posters, but you're not quite sure what clinical practice guidelines mean, or like why they're even out there. So I think we had like four thumbs up of people learning about the guidelines. And then, yeah, maybe in like Instagram comments, or even in our group here in Zoom, if you have heard of guidelines, do you use them, or do you find them helpful? So maybe one person or 2 people can make a comment. Do you use them? Do you find them helpful? Even if you're a student, maybe on practical, but yeah, if you have heard of them, do you find them helpful? Do you find them confusing? Have you found more versions than just one? Give it just a few seconds.
I'm gonna practice my track movements.
Track movements here.
I'm gonna do it as a 180 of Brandon on a stool. Sorry, I mean a very expensive track I bought this morning.
Yeah, a steady cam.
Look at that, eh? So, no comments yet, but
that's okay. So we had one in Zoom, and they said they've like seen posters in their office, but they just don't understand like why they're there. So that's great. I think that's an awesome answer, because we have these like well-researched guidelines But again, they don't translate well to patients and clinicians. We see them as patients who are like, okay, that's great, but what does that mean to me? And as clinicians, we're often like, okay, that's great, but how do I do this in my clinic? How does it help me in particular? How does it help with my patients that I generally see? So in Alberta, or in Canada, I guess, one of the major ones is what we call the TOP clinical practice guidelines. And then maybe what we'll do, I'll give like maybe like a link dump with some of the content today.
Yeah.
We'll do it on like Instagram or maybe our webpage on Facebook. That's not a web page, but you know what I mean. A
People
Facebook
can
page.
direct message me as some have been doing, which is great, and I can send you.
So I'll drop links for guidelines and also that the MSK tool there as well.
You know what I could do is I have a Google Drive that has all of our videos.
We'll share the drive. But generally, what they are, so they're researched recommendations for the treatment of low back pain. Okay. Now, when I say research, they usually come from systematic reviews and meta-analysis, which are kind of like at the top of our information pyramid of gather information as like researchers. But they usually also involve like an expert committee of people that kind of organize them and say, you know what, in clinical practice, these make sense for people in practice as well. As clinicians, as students, even as young clinicians or even practiced ones, sometimes guidelines can get confusing because some are actually really good and some give a lot of information. Others actually are like, okay, this is not very good information. It's mostly just expert opinion. We actually don't know if that's good or not. So one of the tools we do to look at that is what we call an agree tool, AGREE. It's you kind of look at it to see if information is there and you kind of vote on it. But let's just take a quick scan of this one. So one of my favorite ones, what is the top recommendation we see on here? What is it, Sunny?
The top, patient education.
Patient education. There we go.
Like to do
it's number one top recommendation, patient education. So it brings me back to that whole two-way street between patient and clinician, starting to talk about what's going on, really opening the door, start to think about, let's make those practical goals. Let's start talking about expectations. What are we doing here? What are we doing with our doctors? Blah, blah, blah. So as you can see, it comes from a systematic review. We're not going to click on which one because these are probably out to date already, but we won't talk about that. And then what's number two, Sunny?
Exercise.
Exercise, number two. So number one, number two, patient education, patient exercise, huge databases, lots of big systematic reviews, lots of good evidence. Talking about what two things we should always be doing with persistent low back pain. So those are kind of number one and two on our list. What are some things we don't see here? And Sunny, maybe I'll talk about some. Modalities. Shoe inserts, or orthotics for back pain. Do not recommend. These are sometimes we'll see in like advertisement. Your back hurts, get orthotics. Well, probably not. Maybe in a small population that might work.
Even lumbar supports. A lot of people buy those. Tons of people buy those.
Should I start to brace my spine with a lumbar support? Well, probably not. The recommendations just aren't there. We're not going to talk too much this end because they're actually question marks. And they're probably going to continue to be question marks for a while as far as manual therapy goes. And when we talk about this, a lot of populations of patients do respond well to manipulations, to manual therapy, which aren't manipulations, but just movement. But sometimes it's more complex than actually just trying to move tissue on its own. Is it actually being the clinician there and you guys are talking about what's going on and why you're doing this and it's helping getting the muscles moving? Is that giving a positive factor? Yeah, maybe. Mm-hmm. But in general, as far as most physical therapy treatments goes, manual therapy, exercise, and patient education. Usually, if there aren't including these two, education and exercise, probably not going to be a super effective treatment cycle if they don't kind of include those two of what we're seeing as far as what guidelines are. I think there's some interesting ones here. I'm not going to take a look at those. I think there's like some ones at the bottom here. I'm just going to take a look. Sorry for talking out loud here. I return to work. Yeah, that's good. I swear this one, oh, here we go. So like bed rest, those are like things that are like proven to totally be wrong. We shouldn't stay in bed with chronic low back pain. This is what I was talking about earlier, over imaging. Generally, if we have a good imaging study at some point, red flags are ruled out. We don't need to keep beating the horse. Lack of a better term, though, it just kind of can raise questions. Yeah, not too much traction. I don't think Sunny's seen a traction bed in like a while.
It's been a while. You know,
Yeah.
I was gonna potentially purchase one for this place, and then looked at the research, and I'm like, I don't think it's worth $50,000 or whatever the
And
cost
that's
is.
why, right? We just is what we know about it. It just like it's not worth what there's better therapeutic value. And then I think Yahya was asking me questions a while ago, but here you go, Yahya. Ultrasounds. This comes on the guideline of things that probably don't work with low back pain. Even this is interesting. Like it has 10s on here that don't necessarily work with low back pain. Keep in mind this is like on its own, and this is what I was talking about. Injections and stuff like that. These are like tier 2 things that even down the road of things that generally we could is that get tried, but sometimes they're like the first thing that are offered in like a doctor's office. Hey, Sonny, we're going to give you for your back pain, you've been coming in here, we're going to give you why is my mind not thinking about it? What's the most common NSAID prescribed?
Not Voltaren, but naproxen.
Naproxen, there you go. Sonny, we're going to use some naproxen. We're going to send you for an x-ray. Great. Those are 2 things we'll know. That's probably something that's not going to give a really positive treatment intervention, especially with somebody that's been dealing with back pain more than 4 months. Maybe you're a cute guy. Yeah, maybe, but not any of the other people. And then we get a lot of different kind of question marks here. Where's one? Yeah, there we go. That's a whole other topic. So like acupuncture, back schools, all this other stuff that we still have a lot of question marks on. Yoga, shockwave therapy, touch therapy. I don't know what that is.
No clue.
Maybe Sunny could.
I don't know.
Yeah, I don't know.
I can only guess.
So these are just things, a question mark as far as guidelines that we just don't know enough about to recommend it as an intervention from that end. All right, I'm going to stop sharing my screen. Okay, so those are what practice guidelines are. Those are what generally low back guidelines are. There's some other ones. I've like NICE, N-I-C-E, NICE guidelines. That's kind of interesting. They're out of UK. Those are ones that they've made. There's a whole bunch of other ones. If specifically guidelines, they change year to year as information changes. But generally, with low back pain and chronic pain, as we said, exercise and education have like some of the highest therapeutic benefits. And it's one of the reasons when I say that, why they're like the top 2 on guidelines, because they're just so well researched, why we include them. And that's why even like tele-rehab is in our practice, right, Sonny? Because those are things that we can deliver the patients through a screen here, where we don't need to be necessarily working on you at home. But that's something that's why we deliver tele-rehab, is because we can have an effective treatment and planning based on those factors there as well.
Yeah, and it works very well.
Yeah, and I think Sonny's tried a few sessions. And what do you think of it?
I think it's great. I get to deliver everything. I even did an assessment, because initially my confusion was like, how do I assess somebody?
Awesome.
And we made it work, right? We did some like isometric strengthening of the knee, like tests, instead of like, doing a pushing against the knee. I just had the person push against the wall and pull against a door, and it worked out very well. Like I was still effective. Took a similar amount of time, and they got better. I ruled out the serious stuff. I mean, again, if it was serious, then yes, you got to come in at one point where we need to put our hands on you, so to speak.
Yeah.
But yeah, like you said, that you still get the education, you still get the self-management, and you get the exercise done.
Yeah, and planning too, right? It's like,
Yeah.
okay, this is, and what's interesting too, and as far as chronic pain or even low back pain in particular, remember that fear avoidance cycle we talked about. What Sunny is doing in his tele-rehab assessment and treatment is that he's trying to break that. Okay, there's no fear, but this is what's probably going to happen in the next week. This is what you're going to work on, and kind of really breaks that cycle, and you start to get back to that recovery, or get out of that acute injury, which I guess is not so much chronic pain, but still shows the importance of those pieces. Okay. So that was the last guideline that I'm going to talk about from that end. The last little bit is I'm just going to talk a little bit about Glad Back and what Glad Back is. And those who saw the webinar this morning have a really good idea what it is. So it is basically a program that rolled out in Denmark, and it uses guidelines, so kind of the best evidence that we kind of have, and rolls it out into a program that, oh, sorry, 1 second here. Oh, is it,
Yeah. So there's
awesome.
patient experience of getting,
really good.
I guess, pills and rest, but sometimes we don't need. Then people interpret rest as different, or may explain as different. For me, rest means like get off the activity that caused the issue, but still stay active. To others, rest is like lay in bed. Yeah, so there's obviously quite a variation. So what it is, it's a program from Glad Canada. You've probably heard of Glad Hip and Knee. So it's a group-based class that works on those big pillars of education, self-management program, and exercise and movement to kind of get back. And of course, data entry, which is important too, because how do you know interventions are correct if you don't know the data behind it? Exactly, yes.
So that's kind of from a Glad Back. Takes those guidelines, put in a nice convenient package for clinicians and also patients to know what they're getting as a product, and clinicians as well to how am I going to get all these guidelines into one spot? Okay, great. It's a nice little package that we can deliver as far as our patients from that end. And when curious, probably what's going to look like one of my PhD projects is going to be looking if we can deliver it through like a telehealth type platform, because that'd be neat, right? Could we deliver guidelines or evidence-based low back pain treatments for chronic low back pain over like a model like Zoom, for example, so that people could get the best benefit, even if they can't leave their house, even if the pandemic, whenever it's over, those people that can't quite get to the clinic, or let's say it's later in the evening and the clinic's closing down, but you can still see that therapist, great, makes it more accessible for everybody as well. So that's kind of management in a nutshell. There's quite a few things we kind of talked about, but I hope some of them were helpful for patients and clinicians. Maybe we'll just open up for questions for like the next 5 minutes, or if there's more information people want to know. I think we got a few questions.
I'll upload those documents.
Yeah,
onto the Google
we'll give a
Drive.
little link dump. Or,
I purchased more data, so
good.
a whole $2 a month for an extra 100 gigabytes.
Perfect.
Does Glad Back also target patients with arthritis? Which other populations do you find benefit from the program? This is a great question.
Really good. So osteoarthritis, 100%. Those are kind of the populations that we deal with quite a bit. So I guess there's two schools. One is Glad. Is this a brand name? One is there's Glad Hip and Knee as well. So a lot of people with hip and knee osteoarthritis will attend those programs. Those ones are really, really well laid out, and I shouldn't say they're really well done as far as, and there's lots of places that offer them. So Glad Hip and Knee, if that's osteoarthritis in knees or hips, that's a really good place for you to go, and it has really, really good benefits. Really, really good. And then Glad Back, same thing. Even if it is osteoarthritis, or you're saying, if it is in the back where you're getting that pain, same thing. Those are the people that we're looking for. Those are people that we generally see do really well in this program. Excuse me, is those people as well. So good question.
Good question. Yeah, it's a good program. Even for from a patient perspective, if there's more information, if you need more information, let us know. It's cheaper too. So you get. Now, if we talk about the promotional content, it is a bit cheaper for people to do. You do it in a group-based setting, and the price is reflected, and you're paying a fraction of the cost of treatment, and getting the same benefits. So if people have limited extended healthcare, for example, then they can take advantage of that program and get quite a bit of help, right? So
and from a research side too, one thing and clinicians as well that may be interested in taking the training program at some point to be a clinician is that well, the way I look at it too, you get that works out to about 16 1-hour sessions, one-on-one, not one-on-one, but 16 1-hour appointments with these people, which is a ton of time, like 16 hours of education and exercise. Pretty not common.
Yeah, you don't
uncommon.
Get that. Uncommon. Yeah. Opposite of common. Decommon.
Decommon. So yeah, it's a perspective. Remember, it's a program, and it's not for everybody, but I think it's good because it looks at a lot of those guidelines and says what works and what doesn't.
Yeah. No, it's great, and I'll put those documents in the Google Drive. Message me. I think there's one person I have to message on this about the Google Drive. I'll send you a link for it. And it's constantly updated. So that same link will work for good. And then it will be constantly updated every day with our new videos. So share that around as you see fit. There's lots of good resources. Like each video is titled of what joint or what injury there is. And then you can kind of go through which ones you want to go through. And I'll put the GLAD documents as well. And we'll keep that for good, I guess, because we'll have a big resource by the end of all of this. We'll go through the whole body.
Yeah, exactly.
We'll do anatomy day.
Yeah, and then I guess the last kind of comment I'll kind of leave everybody with here is that remember proper management for chronic pain takes a team. It often, as a physiotherapist, you are part of that team, and remember that. So that's proper communication with medical doctors, chiropractors if they're seeing them, psychologists, even pharmacists. Remember, everybody plays a role to make a really good intradisciplinary team atmosphere that is really centered around the patient. So again, even as patient, you are the center. So make sure you are asking questions and make sure you are building your team, your all-star team.
Yeah.
That's working for you to be that as well. Yeah.
Exactly. Yeah. So. Sorry, Brooklyn, you just joined, but we will put this on our story and it's recorded. So
yeah, exactly.
And then I'll post it on the Google Drive and we'll have it available for everybody. And easy one for me. I just got to sit back and be the cameraman, which is kind of nice.
Yeah, exactly. That's good.
And then tomorrow we're doing running injuries. So focusing on the knee and shin splints. So feel free to attend that. Rob will be here tomorrow as well. He's the bigger runner out of me and him and I. And yeah, we'll get some good stuff, good content tomorrow. And then feel free to message us about any injuries that you want us, or any conditions or any topics that you want us to expand on. Next week, I got some Toronto guests, which I'm very excited about. So a very good friend of mine,
Drake,
my BFF.
Drake,
sorry,
Drake.
Drake's
coming.
Drake's gonna be on here. So he's going to be with me next week, which is exciting. My goal is to connect with other physios in Canada.
Nice.
Every province and territory be a good PR, a good record.
That'd be neat. Yeah.
And there's another great therapist in Toronto as well, who's going to be doing the pelvic floor, so women's health and things like that, which we're very lucky to have as a treat. And then
I think Tuesday you said Connor McDavid's coming.
Connor McDavid, yeah, he's coming in. We got Michael Jordan doing a layup seminar, slam dunk comp. Who else? I don't know. We got Michael Jackson somehow. No.
Yeah,
that's too far. I'm sorry.
Yeah, all good. And then to add to Sunny's comment too, if you have me on Instagram as well, what's my Instagram? Brandyn
Powelske PT.
Yeah, Powelske PT. You can always just direct message me too if you have questions. I'm always open to those as well. Thanks everybody, and I'm going to just answer a few more questions on Zoom here. And but Instagram,
we got a minute and 14 seconds.
Yeah, I'll leave it on.
So
it's on there as well.
We'll leave you guys on for now until you automatically get kicked out. Oh, show and share. Oh gosh. We had a comment about as long as Anatomy Day isn't a show and share. Yes, we will make sure of that. That's not going to be a show and share. So then tune in every day, guys. 12 o'clock, Monday to Friday. Weekends are off, I guess. I'm still here on weekends, but yeah.
Yeah, Sunny's making Rob work the holiday tomorrow.
Yeah, I'm working the holiday for free, so nothing for that. All right, guys, take it
Thanks,
easy.
guys.
A few seconds
Yeah.
left, and
Take care.
And we'll see you tomorrow, hopefully.
See
Bye.
you.
Be nice to each other.
Thanks, Zoom people. We're gonna end it now. Thanks for coming by.